slides?
Yes.
Yes.
Okay, so I'm going to give a few minutes updates on management of persistent epithelial defects. And my name is Christopher Liu. I'm co-chair and I work from Brighton in the United Kingdom. I have no declaration of interest, but huge thanks to Mehran Sarai Ganavati, this gentleman here, who reviewed 1,500 papers on the subject for me. So you're all familiar with what a persistent epithelial defect looks like. This picture is courtesy of Professor Claes Dolman, and you see that this area will refuse to heal, and there's heaped epithelium there, and sometimes there'll be some deposits on the stromal surface as well, making epithelialization more difficult. Sometimes there is reduced sensation, making healing difficult. So the definition of a persistent epithelial defect is the failure of re-epithelialization despite 2 weeks of standard therapy. The diagnosis is by detailed examination and history taking, paying really careful assessment of topical and systemic medications because these can have bearing. And attention to the patient's general appearance, the face, the blinking and the lids, as soon as they walk into your consulting room. It's important to measure corneal sensation, assess the tear film, including tear production, and a full examination of the ocular surface, which means lid margins, lashes, distichiasis, eversion, including eversion of the uplids, and as I said, examination of dry eye, exposure, any stem cell deficiency, and any keratinization, including bulbar and keratinization. So the etiology is often multifactorial, including reduced sensation after infection, inflammation after surgery, and so on. Drug toxicity, especially topical drug toxicity, including toxicity from preservatives. So the management is determination of the causative factors, which are often multifactorial, and then addressing them. So lack of sensation and infection, especially with herpes simplex, the simplex virus, and toxic causes are usually missed. So we must remember a whole list that we need to look out for when examining the patient. So I would advocate a stepwise approach to management, beginning with conservative treatment and progressing to more aggressive options if refractory. So there are actually many treatment options, and some of them I favor for personal reasons. Some others favor, maybe they're more used to it. So we'll go through them and see what's what. Supportive treatment, very important. So reduce topical medications and use unpreserved drops if possible, or ointments, because ointments is on the whole unpreserved, and also it stays on the longer period. The resident time is very long. Aggressive lubrication using preservative-free artificial tears, gel or ointment, and punctal occlusion, either temporary or permanent, and sometimes a low-dose topical antibiotic for prophylaxis of infection. If you have stromal abnormality, so for example, if the stroma is inflamed, it's not good for epithelial cells. If the stroma is coated, then it may need freshening with superficial keratectomy, either by laser or manually. For example, if you have a vernal plaque, then some people try and heal that with a lot of steroid drops, but often it would be necessary to remove the plaque either by laser or manually through superficial keratectomy. Then you have stromal ulceration, and stepping may not support epithelial growth, and some people like to use amniotic membrane transplantation, often multiple layers. So we'll go into a little bit further. Suppression of inflammation is very important, and basically we're talking about oral doxycycline for quite some time, prolonged period of time. So often we need to suppress inflammation with low-dose non-preserved topical steroids as well. Casicol is a sugar and it was much talked about a few years ago, but it's not really used very much nowadays. Tassorrhaphy, there is almost no pigment epithelial defect, persistent epithelial defect, which does not heal with the tassorrhaphy. So what I would advocate is a temporary central tassorrhaphy. And for that, all you need is just a loop of nylon suture and 2 bolsters. And the beauty of this is that it still allows topical medication. You can apply the medication on either side of the central tassorrhaphy, and you can also examine the eye whilst prising open the eye and asking the patient to look left or look right. So I really do favor that. And after a small number of weeks, there's almost nothing which doesn't heal. So you've got the alternatives here. So this is very old-fashioned. It's not really used anymore. Botox, yes, you can drop the lid, but I don't favor this because the recovery after some time is partial, and the lower part of the cornea is exposed quite quickly, and therefore you don't really have full protection. Similarly, the modern tape splint tassorrhaphy, which involves asking the patient to look down, holding up the brow, and putting a stiff piece of sticky tape onto the upper lid, stiffening it so that it is incapable of opening. Again, is similar to Botox, that the lower part of the cornea may not be fully protected. So what about the use of contact lens? Remember, I think if there is not much moisture, then you have to think about not using a soft lens, because that actually sponges away the water and evaporates it. Now you can use a silicone hydrogel bandage contact lens to protect the epithelium from eyelid blinking, or you can even use a steel scleral contact lens to retain epithelial hydration and protect the ocular surface from and any tarsal keratin. Blood product derivatives are very useful. So you have serum tears, which have many, many goodies within it, and they can come in different concentration. These are the different concentrations. They're all effective and they work very well. But of course, it involves drawing blood and then spinning it down and then storing in the freezer. So it's really quite a palaver. So the alternative, the finger prick autologous method is quite useful, that you sterilize the fingertip and then you prick it and then put the drop of blood from your fingertip directly onto the eye. Now, what about platelet-rich eye drops? Well, these also work very well, but again, it needs to be worked on. And you see it healed within a very high percentage of healing within a small number of days. So how does platelet-rich plasma compare with autologous serum drops? Well, actually, there is higher healing rates of corneal epithelia with the platelet-rich plasma treated eyes. Now, this is the news on the block, and there's a lot of interest in topical insulin, basically prepared at a concentration of 1 international unit per mil, and using that as eye drops 4 times a day. 80 to 90% achieve complete reepithelialization. The optimal concentration may be a little lower. And how do they compare? Topical insulin 1% versus autologous serum eye drops. Insulin was actually more effective. So you think, now we don't even have to take blood from the patient. So this is very exciting indeed. Amniotic membrane, I don't really favor very much because it involves surgery and it's expensive, and being translucent, you can't really examine the underlying cornea very well. And also the eye drops that you put in may not get to the area you wanted to get to very well. Now, if you use the in-office sutureless AMT like Procura, then the success rate may be a bit lower. Limbal stem cell deficiency, I don't intend to go here because it's a completely a big subject by itself. Do look for any limbal stem cell deficiency and treat accordingly as to whether it's unilateral. You can borrow some from the other eye, or if it's bilateral, then you have to think about things like Aluslet, described by Geetha, or Comet, described by Professor Sotozono in Kyoto. So other surgical methods, epithelial debridement, so removing the inactive epithelium at the edges of the epithelial defect, conjunctival flap, so freeing up your conjunctiva and then pulling that over your cornea. Now, this will mean that the patient cannot see through the eye, and even more if you transplant buccal mucous membrane graft, then the patient cannot see. But again, this, like tassorrhaphy, is very effective, but this is kind of permanent because you cannot remove it once it's on. Corneal neurotization, a very, very involved procedure, taking a sensation from the eye and through a big nerve onto the side, which is denervated. So I just bring to you another novel treatment, apart from insulin, is this called cenegermin or oxivate, is recombinant human nerve growth factor. Now, I won't go through the details because there's no time, but I will show the slides. It's being recorded, so you can stop and review and read the papers if you want. So it is very effective, but of course, you can imagine the cost. I will summarize now. Determine etiological factors by history and very thorough ocular surface examination. Reduce topical treatment. Use unpreserved drops and ointment. Lubricate with unpreserved artificial tears, serum tears, insulin drops, temporary central tassorrhaphy. And then these are things, if you really need to, AMT, nerve growth factors, conch flap, Gunderson's flap, buccal mucous membrane graft, corneal neurotization. This really is very much a last resort. So thank you very much. And these are my emails if you want to contact me.